Hi, I'm Alexander Blunt. I'm a professor of clinical psychology at Antioch University, New England, in Keene, New Hampshire. And I want to talk to you today about the importance of behavioral health care in primary medical care settings. We're doing this as part of our workforce initiative to help develop the behavioral health workforce for primary care in New Hampshire and in the region. The New Hampshire Primary Care Behavioral Health Workforce Initiative is sponsored by the Endowment for Health in New Hampshire, and our initiative is working to get more talented people able to work in primary care in New Hampshire and the region to help meet the need of behavioral health care and primary care. And so I'm going to explain a bit about what that is today, and I hope you'll find it interesting. We have to start out, though, with how we think about things. I mean, this is medical care. Why would you want mental health and substance abuse people in there? But people think of those as so separate. We think of the mind as different from the body. Is it emotional or is it physical? We often say. We think about that we have separate service systems. There's the mental health system and the medical system. There's mental health funding and there's medical funding. Different training systems. There's medical school and there's various kinds of training for mental health, but mostly they're separate. And these two systems have very different languages and ways of caring. Mental health tends to be more reflective, more sit with one person and talk to them about their concerns. And the medical system tends to be more, let's go find it, what's wrong here, let's do something about it. Very different styles. And so the bringing mental health into primary care turns out to be a challenge. René Descartes, we're going to say that René Descartes is to blame for this change, for this problem. It's probably not really fully true, but he was the philosopher who said that the mind and the body were really different and that you could do life of the mind that didn't relate to the body, and that whatever happened in your body didn't relate to your mind or your soul. And so you didn't have to worry about them being together. And the folks have developed kind of in that mindset for a long time. But primary medical care doesn't quite fit that separateness. So primary care is like the doctor. It's the first contact. Where do you go when you need to go to the doctor? A knowledge to make sense of their complaints that they bring you. It's the place where you bring everything. But it's the front door to the whole system. So whatever's wrong with you, taking it to primary care isn't the wrong thing to do. They may be able to address it all. We've got what you need. They're comprehensive. Or they're coordinating, that if we don't have it, we'll help you find it. And then they take care of what in medicine they call this the undifferentiated patient. And what that means is the patient, we don't know what's going on with them. If you're a cardiologist, if you are a podiatrist, in other words, if you're a specialist, the people who come through your door are very likely to have the kind of illness that you treat. They've often already been sort of sorted out. Someone else has said, no, you have to go to a cardiologist. But if you're a primary care doctor, people come in and, if you have chest pain, you could have a heart problem, you could have a lung problem, you could have a muscle problem in your chest, you could have anxiety. There are all kinds of things it could be, and it's the primary care setting and your primary care doctor who figures that out. So that means primary care is set up inevitably to treat the whole person. But to do that, turns out we need a multidisciplinary team, that we can't just treat a piece of what people bring and refer things out because, as you're going to hear as we go on, it tends not to work. So what's happening now is we're beginning to bring other folks into the primary care team and doing what's called patient-centered care. And the best of patient-centered care means that each patient has the team that fits their needs. And primary care is becoming more and more important in the healthcare system. It is the place where we can do our best work to improve people's health. I mean, a lot of people's health. And it's the only thing that if you do more of it, you save money in the long run. Doesn't seem possible. You do more of something and it costs less, but primary care, that's true. Let me show you. So this funny little graph with all the dots is a map of the cost of Medicare in the different states. Each state has its own statistics on what Medicare costs. And the y-axis, the up and down axis, the x-axis going out is how many general practitioners, in other words, primary care doctors, there are per 10,000 people in that state. So it's a ratio. And what you see is that the more primary care doctors you have in the state, the lower the cost per person in Medicare. This is adults. And conversely, as my English teacher would say, this is the rank of quality of each state compared with the number of primary care doctors per 10,000 people. And what you see is that the more primary care doctors you have per 10,000 people, the higher the quality care in that state. And that proves out in the mortality outcomes. In primary care, if you were to add one primary care doctor per 10,000 people in a state, in other words, we get this by comparing data between states. So if you were to add one primary care doctor per 10,000 people in a state, your mortality rate goes down 5%. And if that primary care doctor is a family physician, the mortality rate goes down 9%. This is real lives being saved by making primary care more central to the health system. And this is who used to provide primary care. There were people in the medical world, they get called providers, although they don't like that term very much, but they are what we call doctors. They are people who are trained with an MD or a DO degree. Both of those are doctor. People went to medical school, or nurse practitioners, advanced trained, or physician's assistant. These are the people who could be the person who took care of you. I call the nurse practitioner and the physician's assistant doctors as well, because that's what their patients tend to call them. Then there are nurses, and nurses can be a sort of a broad range of folks to the patients. They're sort of a nursing staff, I guess would be better to say. Registered nurses, licensed practical nurses, medical assistants, and they help put people in rooms. They take their vital signs, their blood pressure and their weight, and they talk with them about the problems and do an initial assessment of how they're doing. Sometimes they do what's called triage, where they are on the phone and they're talking to patients about their concerns and whether they need to come in and be seen or they could wait a little while. They do injections. They do a lot. The list of what the nursing staff does is very long. And then there are administrative people. They are the reception people, and they do scheduling and billing and those kinds of things. But that really was the main set of people who were in primary care for a long time. And now this idea of meeting all the needs is truly adding to the team. So now we have medical interpreters. We have people I'm calling behavioral health clinicians, who are psychologists, clinical social workers, counselors, who do mental health and substance use services. We have people called patient advocates who help patients present their needs to the doctors and help make sure the doctor understands and helps them get around the medical system so that they can keep their appointments and get better care. Care managers, care coordinators, navigators, which is sort of like what I described for patient advocates, helping people get around the system and not get lost. Community health workers who reach out to folks often in their homes to help them understand the care, their medical treatment they're getting, and help them take the pills or do the healthy behavior that they need, you know, get a little exercise, eat better. Health coaches as well, teaching people how to stay healthy. Nutritionists, pharmacists. I guarantee you, you can find one of all of these people in some practice in New Hampshire and probably around you, wherever you are. So let's talk about behavioral health needs in primary care. And by behavioral health, we mean mental health, substance use disorders, and health behavior needs. In other words, people who need to lose weight or get more active or stop smoking. So what are the needs generally in primary care? Well, all adults versus underserved. What that means is that if you just take the whole population, the percentage of the population that has major depression is about 10%. People with panic disorder, about 6%. Other anxiety disorders, like generalized anxiety disorder, 7%. People with some sort of substance use disorder, 10%. So the number of people who would qualify for any mental health diagnosis is 28% in the study that I'm quoting. And it's about right. For people who are underserved, and underserved in medical talk means low income, have a hard time getting services, or live in areas where there are not many services, have a hard time getting the things that other folks can get to get healthy. They sometimes have insecure housing, insecure food supplies. So people who are struggling and usually have therefore more stressful lives, their rate of all behavioral health needs is somewhere between 2 and 3 times the average of everybody. And so for primary care practices like federally qualified health centers that serve underserved patients, the need is particularly acute. And then, you know, I mentioned unhealthy behaviors. We're now at about 20% of people who are smoking. You can't have a more unhealthy behavior than that unless you're skydiving without a parachute. Your rate of obesity is high, closing on 1/3 of Americans. People who don't get enough activity, enough exercise, is about half the population. We're all wandering around staring at our screens all the time. And non-adherence, that means people who, when they get care, don't follow up the right way. They don't take the medicine the way it's prescribed, or they don't go get the test that they're supposed to get. And that's also very high, and it puts people at risk. And then people have chronic conditions that also have a behavioral health component. So for instance, if you have asthma, but you're smoking, you really need to stop smoking. You need behavioral health help. If you have diabetes and you're depressed, your diabetes symptoms are worse. Not just your depression, your actual symptoms of diabetes are worse. So everybody is at more risk of bad things happening, and their care costs more money when they have a chronic illness with behavioral health needs that aren't met. So let me show you how this tends to show up in primary care, because you would think, okay, if you have depression, we'll send you to a health psychologist or a clinical social worker who works in healthcare. That will work great. In fact, in primary care, it shows up in very different ways. And so often the doctors themselves don't recognize the behavioral health need that they're looking at. So this is an example of how a doctor might look at her schedule in the morning and look at who's coming this morning. And so let's say here is a 56-year-old woman who's a diabetic, and she is in poor control, meaning her diabetes is out of control. And when that happens, a lot of parts of your body are at risk. Your eyes are at risk, your limbs are at risk, your heart is at risk. So this is a serious thing. Then you have a 19-year-old who's here for a physical exam, PE, physical exam, who's a smoker. You have a 33-year-old person with a lot of different body complaints, somatic complaints, or body complaints. And they're called multiple somatic complaints because there's no one particular illness or problem that's being presented. A 7-year-old with otitis media, which means earache. A 67-year-old who can't sleep with insomnia. A 70-year-old with sinusitis, meaning a sinus infection. A 52-year-old person with high blood pressure. A 45-year-old person with tinnitus. Tinnitus is chronic ringing of the ears that doesn't go away, and it's very distracting. 38-year-old person with acute asthma, that's a risk, that's a concern. A 29-year-old with pain and shortness of breath. SOB in medical speak is shortness of breath, not an insult about the patient. So what would be the mental health issues in this schedule of patients? Well, it is very common that someone who comes with multiple somatic complaints also has depression. Depression and body pains kind of go together for a lot of folks. Our 67-year-old who can't sleep is also abusing alcohol. You know, a lot of people drink to go to sleep, and then alcohol ruins your sleep. And so even though they get to sleep, their sleep isn't restful, so they're more stressed and tired the next day. And sometimes they're also more anxious if they drank a lot the night before. And so then they drink more to settle down to go to sleep again. And it becomes a real vicious circle. And then a person with chest pain and shortness of breath could very well have panic disorder rather than heart problems. It just, when you have a panic attack, it feels like a heart attack. It is, for all the world, feels like you're having a heart attack. So there's also psychosocial distress, meaning these aren't things that necessarily have a mental health or substance use disorder diagnosis, but they're real issues and stressful in their lives. So our person with diabetes in poor control is anxious about her health. We wouldn't say that she has an anxiety disorder, but she's worried all the time and could very much use some help in that area. Our 7-year-old with an earache actually is also wetting the bed. And so that's something that behavioral health might very well deal with. Our 70-year-old with sinus infection, she's actually a victim of family violence. She's got her grandson living with her. He's in his early 20s, and he drinks too much. And she told him he had to shape up, and he pushed her down. And she's very worried and concerned. But nobody's asking her about her grandson. They're saying, let's fix your sinus infection. Seems pretty straightforward. And then person with tinnitus has hypochondriasis, which means that they see every little discomfort as likely the first sign of a dread disease. So they're very worried, and there's a lot of behavioral health concern there. And then there's the behavior change, living more healthy, that a lot of these folks need. So our diabetic in poor control, she is obese and she's smoking, and that would make so much difference to her if she could lose weight and stop smoking. Our 19-year-old smoker also needs smoking cessation care. Our hypertensive person has cardiac risk factors, meaning he's too angry and he's eating wrong, and his what we call lipids, meaning the fats in his blood, are wrong. He needs to make some changes to stay healthy. And then the person with acute asthma is not taking her medicines. So she's not complying with her medical regimen. That's common with asthma because asthma has two kinds of medicine. One is called a rescue medicine and one is called a maintenance medicine. And if you take your maintenance medicine, it doesn't make you feel any better, but it saves you from having attacks. If you take your rescue medicine when you have an attack, it makes you feel much better. So you're supposed to take your maintenance medicine and not have attacks, and a lot of people don't do it. They just take the rescue medicine, which is not healthy. So here are all of these behavioral health needs, and this is how likely they are to accept a referral. If their doctor said, you know, you have a real behavioral health issue here, we have a health psychology practice across the street, I'm going to refer you over there. How likely are they to go? And so the diabetic isn't going to go because she thinks of her problems as medical. I don't have a mental health problem. I have a medical problem. So we just need to fix my diabetes. The smoking cessation person is in what we call pre-contemplation, which means he's not even thinking about changing now. So he's not going to go. The somatic person with depression, I use the term cultural factors because in some cultures, the idea of depression doesn't make a lot of sense. They don't think of things that way. They tend to experience when they're down, experience in their bodies. And so they think of things as medical. And if you say to somebody, you have depression, you should go get help, they find it very insulting. The child who's wetting the bed, they think of the doctor as being the person who should deal with that. They're wondering if it's a medical problem. The person who's drinking, ETOH means alcohol, only told the physician to see if it was going to be dangerous for them. He did not tell the physician because he wanted a referral. He's not looking to make a change. The person with family violence going on is afraid that if it gets revealed because they get counseling of some sort, that it could come back to make it harder for the grandson that she's trying to help. So she's not going to do it. The cardiac person with hypertension, it's not covered in mental health. You can't say I'm going to a psychologist or a social worker because I have a heart disease. In most places, that isn't paid for. The person with hypochondriasis would feel blamed. They would say, you're telling me it's all in my head? No, I'm so worried. You have to do something about this. The asthma person has family issues, and family issues are very common. For instance, people take medical advice from their family. And so she's not taking her asthma medicine because one of her family members says, don't take those other pills. You should not take any more pills than you absolutely have to. And so she's doing what her family member advises, which it's bad advice. She's not looking for other advice. So the person with panic attack and chest pains, I guess, is a possible referral, although people with panic attacks often won't go because they still feel like they have a heart problem. So in all of these cases, we have 10 out of 10 that have a significant behavioral health issue and 1 to 0 out of 10 that are a possible referral. Plus, it's worth noticing that underserved and minority populations are particularly affected by the lack of access to behavioral health somewhere else because, as the Surgeon General's report says, racial and ethnic minorities are less inclined than whites to seek treatment from mental health specialists. Instead, studies indicate that minorities turn more often to primary care. So as a group, minority folks are looking for their care in primary care and not that willing to be referred. But that's just like a lot of people. The bottom line here is that the vast majority of people will not accept a referral to specialty mental health or substance use services when it's offered by their primary care provider. It is care in primary care or none. And so this is the background to why bringing behavioral health care into primary care is so important and so necessary to meet the behavioral health needs of the population in our country. That's my last slide. So we're going to have 3 more modules. We're going to talk about what primary care behavioral health looks like, how it's delivered, what kind of programs we have there. We're going to talk about how that changes primary care and about the whole team, because many of you might be interested in being on that team, even if you weren't on it as a behavioral health provider. And then we're going to talk specifically about what your choices are for if you were interested in a career in primary care, either in the medical side or the behavioral health side, because there's a lot of roles that aren't the doctor or the mental health person that are necessary and that are part of the helping both medically and behaviorally for patients. And they're interesting roles, they're exciting roles, and I'd like to tell you a lot more about them. So thank you very much. I'm going to stop here for today, and I hope you enjoyed this, and I hope you'll take advantage of the other modules that will also